topic, that is the interpretation of blood CP, and you can diagnose a variety of diseases, and you can say what is going on with this patient, what is wrong with this patient by looking just as the blood CP. The specificity of a blood CP is very high, but the sensitivity is low. What does that mean? It means if there is abnormality in the blood CP, specifically the patient is having the problem, dig out the problem. But if the blood CP is normal, the sensitivity is low. It means patient may or may not have the problems. So it depends upon the history, the clinical examination, and other investigation. So how do you check the validity of the blood CP? That this blood CP is done correctly by machine. So you take the ratio of the hemoglobin to hematocrit. If that is 1 to 3, this is right. How? Multiply the hemoglobin by 3. If the answer becomes equal to hematocrit, it's right. For example, say hemoglobin is 15 and you multiply 15 by 3, that is 45. The expected hematocrit is 45 and the hematocrit given is 45. So if they coincide, hemoglobin, the normal ratio is that 1 to 3, and we have to see whether the ratio is maintained or not. If that ratio is not maintained in the blood CP, repeat the blood CP before moving on to other parameters. Next thing is hemoglobin is normal, hematocrit is normal, the MCV is high or low. What is the problem? And we have seen a lot of cases we are doing extra investigation which was not supposed to be done. So if this is that while in which you are going to take the blood for blood CP, if you do not take the blood up to the mark, what will happen? You have taken less blood, and the EDTA or the anticoagulant that was in the blood CP vial, that draws the water from the RBC that was supposed to be diluted up to this mark. So if that water from the RBC, what happens? The RBC shrinks. When the RBC shrink, that give you smaller MCV. Now if you take more blood than that point, what will happen? The water entered into the RBC and that gave you high MCV. So if the HB is normal, hematocrit is normal, but MCV is high or low, repeat the blood smear, repeat the peripheral smear, or repeat the blood CP. Next thing is, how can you diagnose the alpha thalassemia or iron deficiency anemia from the blood CP? Well, the answer to this is the Menzer index. This will not be the final diagnosis, and this will not be revealed to the patient. A lot of times there are errors in the machine that is doing the blood CP. So before breaking the news of thalassemia, you have to confirm with the iron studies in the serum ferritin and the genetic studies and hemoglobin electrophoresis. But when will you suspect this? You apply the Menzer index. The Menzer index is, you divide MCV by RBC. If that is more than 13, this is iron deficiency anemia. If that is less than 13, this is alpha thalassemia. Because in majority of cases there is confusion. You are giving iron to the patient, but there is no response. The hemoglobin is not improving, and the anemia is microcytic hypochromic anemia. So that is the answer. Apply the Menzer index, and if that is less than 13, this is thalassemia. Why less than 13 in thalassemia, more than 13 iron deficiency anemia? In iron deficiency anemia, your RBC are not producing. If your RBC are not producing, so the MCV by RBC, of course the MCV is down, and the RBC is also down, but the decrease in RBC is more as compared to the MCV. So if you divide a bigger number by a smaller number, it will give you a bigger value. In thalassemia, the RBC is producing in a rapid rate. RBC is producing in a rapid rate. So in thalassemia, you are having MCV is decreased, but the RBC is high. So when you divide a smaller number by a bigger number, that will give you a smaller value, that is less than 13. So that is the concept behind that. Now what is the difference between blood CP and peripheral smear. Blood CP is done by a machine. You just give the sample, the machine takes the sample, and you get the result. Peripheral smear is the process of looking into the blood by a hematologist. The hematologist, they prepare the slides, and then they look under the microscope to look for any abnormality in the blood. So smear is more superior than blood CP. Smear is more superior than the blood CP. If you suspect some problems in the blood CP, go for peripheral smear. Now coming toward the main bulk of the lecture, that is, if the patient is having low HB, low hemoglobin, what is the next step? Look at the MCV. The MCV is low, normal, or high. If the MCV is low, what will you suspect? Iron deficiency anemia, thalassemia on the top. If the MCV is normal, what will you suspect? Anemia of chronic disease and hemolytic anemias. And if the MCV is high, what will you suspect? Megaloblastic anemia. Low HB, how would you proceed in a blood CP? Look at the MCV. If the MCV is low, normal, or high, we are having differentials. If the MCV is low, what is the most common cause of low MCV? Iron deficiency anemia. So you do iron studies. Serum ferritin is low, total iron binding capacity is high, and transferrin saturation is low. This is iron deficiency anemia. Find out the cause, treat the cause, and replace the iron. If the iron studies are normal, what is the best next step to do? Hemoglobin electrophoresis. The second most common cause of low MCV is thalassemia. The second most common cause of microcytic hypochromic anemia is thalassemia. If the hemoglobin electrophoresis is normal, what is the best next step in case of low MCV? Bone marrow. Exclude sideroblastic anemia. And if the sideroblastic anemia is excluded from the bone marrow, what is diagnosis? That is anemia of chronic disease. Find out the chronic disease. Anemia of chronic disease can present with the low MCV and normal MCV, but mostly it presents with the normal MCV. But if you have excluded all other causes from the low MCV, including the lead poisoning can also cause the low MCV. So if all the causes are excluded, then it is anemia of chronic disease. Find out the chronic disease. Now if the MCV is normal, what are your differential? Anemia of chronic disease, acute blood loss, hemolytic anemia, CKD, and aplastic anemia. In CKD and aplastic anemia, the size of RBC, that is normal. Well, in some cases, in aplastic anemia, the RBC size may become high. In some books it is mentioned. So it can present with megaloblastic anemia as well. The aplastic anemia, the macrocytic anemia, it can present with the macrocytic anemia, but most common it is normal size. If the MCV is high, the megaloblastic anemia, hypothyroidism, liver disease, and the drugs, these are the main causes. That is called the macrocytic anemia. How would you differentiate the megaloblastic from other causes? Hypersegmented neutrophil that can be seen on peripheral